minutes. So thank you very much, my friends, for the invitation, and thank you to be here in a Sunday. And we'll talk about a particular anatomy of ETV, that is the Liliequist membrane. As we know, to perform an ETV, we need to communicate the third ventricle with the interpedicular cistern by opening the floor at the tuber cinereum. And the tuber cinereum is a thin layer of gray matter below the ependymon of third ventricle that goes to the infundibular access to the mammillary bodies. And in ETV, CSF is diverted to the subarachnoid system. And like this case, it's aqueductal stenosis we have here, the tuber cinereum, and it's a very nice anatomy, and it seems to be everything nice to perform the ETV. But when we open the tuber cinereum, we see another membrane here that we need to work on it. And this is the Liliequist membrane. And we do not open the Liliequist membrane, the ETV will not work and will not be able to communicate with the cistern. The Liliequist membrane is an arachnoid structure. It is below the tuber cinereum, and it's the upper limit of the interpedicular system. So to conclude the ETV, it's always necessary to open the Liliequist membrane, like here, the Liliequist membrane is here. And sometimes we have the lucky to open the two structures together in the same maneuver, and you do not care with the Liliequist membrane. Like that, we are open the tuber cinereum, and the Liliequist membrane is open in the same time, and we even barely see it. But in other times, we need to open it in separated, in different surgical maneuvers. Like that, we've opened the tuber cinereum, and then we need to work hard in the Liliequist membrane. Otherwise, the ETV will not work. And we need to see the system. As we know, Liliequist originates in the posterior portion of the sila, and it splits in the most of the case in two portions. The diencephalic leaf that connects the diencephalon to the mammillary bodies, and the mesencephalic leaves that attach along the junction of the midbrain and the pons. Here is the neuroendoscopic view of the encephalic portion in contact with tuber cinereum, and here is the mesencephalic pons involving the midbrain. So most of the times, the mesencephalic leaf has an upper overture like that, and communicates, it's a natural communication of the interpedicular cistern to the prepontine system. But sometimes this border is not open, and we need a third maneuver to perform to open it. So as we see, it's very important to know the anatomy, the Liliequist membrane anatomy from the neuroendoscopic point of view. We know very well, very nice pictures like that showing the classical descriptive anatomy of the Liliequist membrane. And as neurosurgeon, we are we know very well the Liliequist membrane from microsurgical anatomy, especially because of the vascular surgeries. But this is what we saw in neuroendoscopy. It's a completely different angle of view and point of view that differs the conventional anatomy that we are our areas. So we have adult. We know that ETV has a discrepancy in literature because many authors consider that there's lower efficacy below the 2 years of age. And we wonder if it's not for the fact that we don't know well the anatomy of third ventricle, tuber scenario, and especially Liliequist membrane in this age group, in pediatric age group. And this is the cause of the discrepancy. So we proposed our work and to study anatomical characteristics of third ventricle, floor, tuber scenario, and Liliequist membrane by the view of neuroendoscopy, compare with the etiology and age, and see if there are some patterns or some details that could interfere with the efficacy of endoscopic third ventriculostomy. So we need to work. We studied 57 ETV at BioCore in a prospective way. And after the procedure, we filled a questionnaire that was the questionnaire about anatomical and technical details of the surgery. We consider a normal tuber scenario when we saw the infundibular access, the hypothalamus, and the mammillary bodies. When the tuber scenario altered, we described the alteration, like in those cases. Those alterations are compiled in 3 more changes: tissue alteration, distorted anatomy, and hemorrhage. And as we have easy or difficult criteria to open the floor and the Liliequist membrane, we performed face validity with 7 Brazilian neurosurgeons with experience in ETV, pediatric neurosurgeons. Those are the colleagues, we thank all them. And then they find what was easy or difficult to open the floor of the third ventricle, and was easy or difficult to open the Liliequist. So we follow these criteria, and our colleague, Dr. Leopold, made this movie to better understand that this is a normal tuber scenario and easy to open. The Liliequist and the tuber scenario are together and open together, and we just need one maneuver to be sure that the cistern was open. And here is another case, a myelomeningocele case, that is the tuber scenario was completely different, as we see, and the anatomy was distorted, and it was very difficult and very hard to understand the anatomy and to open the tuber scenario, and we need many other maneuvers to open the Liliequist membrane. So this is what we need to explain what's the difficult for the surgery. We be sure that the cistern is open. We divide the etiology in 5 types. And the age group, we create one group until 24 months that we called infant. It's our most interest. Child until 11 years, adult and seniors. And we followed 26 patients for at least 3 years. He recorded the evolution. We have some interesting finds, and the first one is that 75% of the patients were in the pediatric age group, and almost half of them are infant, below 2 years. And we have many incidation of congenital malformation. And of course, these congenital malformation are associated with infant and child. Tuber scenario in third one of all case, tuber scenario was altered, and in 26% it was opaque. When the morphology of tuber scenario altered, especially in congenital malformation, and when it changed, the floor was almost always opaque. Opening tuber scenario was difficult in 39% of all cases. So in all surgeries, 39% it was difficult to open the tuber scenario, not the Liliequist membrane yet. And in 1/3 of the case, Liliequist membrane was thick like that. So this is a thin Liliequist membrane. It's easy to work, and this is a thick membrane that's hard. When TC morphology changed like that, opening the Liliequist membrane was almost always more difficult. In 79%, when TC was opaque, open it was difficult. In 60% of opaque tuber scenario, the Liliequist membrane was thick. And when TC was opaque, opening the Liliequist membrane was more difficult. The anatomical third ventricle floor alteration also related to the difficult to open the Liliequist membrane, and the difficulty in opening reflect in the difficult to open. And as thicker was the Liliequist membrane, more difficult was to open. We see in the surgery, it seems that everything will be good because the anatomy is perfect, but we've tried to open the tuber scenario like that very easily, but we cannot open the Liliequist membrane because it was thick below the tuber scenario. So we need to work with other tools in order to be able to open the Liliequist membrane. So we had to work on it and then be sure that the cistern is open. And here we see the mesencephalic leaf with the open border, so we do not need to work on it. When the tuber scenario morphology changed, the floor and the Liliequist membrane tend to be separate. And here is the TC and Liliequist membrane together, and here they are separated like that. And opening the floor and the Liliequist membrane apart was a more difficult act. Again, a very nice anatomy. So, sorry. Very nice anatomy, but we see also a good anatomy of the tuber scenario and the floor of third ventricle. But when we've opened the tuber scenario, the Liliequist membrane was there separated from the tuber scenario. So we need to open it in a different maneuver like that. And this is maybe we are not so sure when we open the tuber scenario to open the Liliequist. And what does all this mean? Well, of course, we're talking about the age groups, especially children under 2 years. That was our initial goal. And the interesting fact is when performing ETV in this age group, we'll have 1/3 of chance to find an unusual anatomical tuber scenario. And in this occasion, we will have 3 different types to deal with: anatomical distortion, tissue alteration, and hemorrhage. And in 25% of cases, it will be opaque. And the opening of the tuber scenario will be difficult in 40% of all our surgeries. So pay attention to the data. In 42% of all cases, etiologies will be associated with TC anatomy change. And on these occasions, to open the Liliequist membrane will be most difficult. When tuber scenario was difficult to open, generally open the Liliequist membrane will be also difficult. And the altered and opaque tuber scenario were associated with difficulty in opening the Liliequist membrane. When tubercinary aspect, anatomical aspect changed, the floor and the Liliequist tend to be separated. In this situation, opening the Liliequist membrane will be more difficult. So we are yet inside the third ventricle. We do not reach the Liliequist membrane, and we have a lot of anatomical clues that to open it will be difficult. So after opening the floor, the surgeon will find a thick Liliequist membrane in 1/3 of the times. In 50%, the floor and the Liliequist membrane were separated. In 37%, it will be necessary two separate maneuvers to open the two structures, and those facts made ETV much more difficult to do. Of course, there is a high incidence of congenital malformation in children and infants, and when this occurs, the relationship between the tubercinary and the Liliequist membrane is more complex. Liliequist tend to be thick like that, and of course, there is much more difficult to open the membrane. So when performing ETV, changes in the third ventricle floor, tubercinary, and Liliequist membrane are common and varied. And the technical difficulties are frequent. In contrast, what we listen many times that ETV is a very easy procedure to do. And these difficulties predominate in infants and children. When we saw what case do not have a favorable course during the three years, some factors are associated with ETV failure. TC altered or opaque, anatomical change in the floor and Liliequist membrane, the separation between them, and the need to open it separately. And another situation is that we observed the anatomy by the neuroendoscopic point of view in vivo. There are no many observations in vivo, a description of the anatomy. So we are just learning about that anatomy by this point of view, and we have a lot of work to do. So what did they learn with all that? That Liliequist membranes are variable and may be difficult its interpretation and management by the neurosurgeon. So be aware of the anatomy, be aware with the Liliequist membrane. It's not a very easy procedure as we saw, especially in children and infants. Tubercinary anatomical changes are related to different Liliequist membrane presentation, generally make it difficult to deal. The unfavorable evolution is associated with opaque tubercinary. The separation between the tubercinary and the Liliequist membrane, and the need to open these structures separate. The hydrocephalus, due to congenital malformations, are associated with more difficult Liliequist membrane to deal, and especially in the infants. And as they are more incident in childhood, it can explain the higher failure rate in children under 2 years old. And what does it mean is that ETV is not a very easy procedure to do, as we listen many times, especially in children and infants. And there are a lot of anatomical details that many times we do not pay attention, but are very important to conclude, to better conclude the procedure. I thank you very much for your attention. I am very pleased for you be here in a Sunday, listen to us, and I may answer any question that you have. Thank you very much.